Thank you to Worldsleep2022 for inviting me and to be able to talk to you about treating insomnia in school kids, a very neglected field. So thank you very much for this opportunity. There's my conflicts of interests. So firstly, to answer the question, what is insomnia? And we can do this by, I guess, a process of elimination. So for example, insomnia is not this delicious banana and chocolato gelati. I'm not pausing for effect, I'm just salivating, so there we go. It is not this guitar by your favorite heavy metal band. It is not this amazing piece of artwork that you are not allowed to take a photo of. And it is not some sort of historic monument either, nor is it a selfie or a selfie of a selfie taken with a horse. And in fact, insomnia is not in adults. It is also in children. So insomnia is actually something that happens across the lifespan. So often we've sort of thought that when you turn 18, you can drive, you can go to the pub and so forth, and somehow you're eligible for insomnia. That's actually not true. So insomnia can actually happen if you are under 18 years of age. And if we look back in time to the International Classification of Sleep Disorders, second edition, here is the insomnia criteria for children, and it was termed behavioral insomnia of childhood. And indeed, what I'm going to show you today is a series of randomized control trials. And when we started our first one, this was the actual diagnosis that we were looking at. So I've just highlighted some of these different areas to have a look at when it comes to the diagnosis. So you've got child symptoms meet the criteria for insomnia, and that's a parent report. And there's two types, or I should say subtypes of insomnia. One is sleep onset association, and the other one is limit setting. And we're just going to focus on the sleep onset association because I guess that's what we saw a lot of in our clinic. So falling asleep is an extended process requiring special conditions. Sleep onset associations are problematic and demanding. Special conditions, when they're not present, that's when you can see sleep onset is delayed or sleep is disrupted. Nighttime awakenings require caregiver intervention. So these were some of the key characteristics to sort of give you a bit of a flavor of what this particular presentation of insomnia looked like when it came to school kids. Now we have the International Classification of Sleep Disorders, third edition, and what we've seen now is almost like a lumping of the adult and the child insomnia disorder into one under the category of chronic insomnia disorder. So really, we're looking at the patient's caregiver who observes these particular types of symptoms. For criterion A, you're looking at some sort of nighttime sleeping difficulty. For criterion B, there's some sort of associated daytime impairment. For C, that the sleep problem is not best explained by inadequate opportunity or inadequate circumstances. And that the sleep disturbance basically occurs for 3 times a week or more, that it occurs for at least 3 months or more. So now what we're seeing is, I guess, some sort of recognition that adults and kids can actually have insomnia disorder in the latest update. So that's the diagnostic criteria. What I want to show you now is a little bit of a film clip that was taken in our clinic from a documentary, I guess you could call it, called A Current Affair. Those people that are in Australia know what the quality of this is, which is probably the same as the quality of the video, but nonetheless, we'll just have a look at this.
These bubbles are where we're going to write your thoughts, the thoughts that are keeping you awake or making you feel worried at night.
So Oscar, whose bed's this?
Mum and Dad's.
So why were you in it?
Because I woke up in the middle of the night and I find it hard to get to sleep because I usually hear lots of noises, so I come down here and hop in. Sometimes I believe what happens in movies and everything.
So hopefully that gives you some sort of sense of what it can be like for a family and for a child when it comes to having this type of insomnia disorder in school kids. So that particular child was in our first randomized control trial, and that was conducted by Sarah Payne. So what we really wanted to do is we didn't have much in the literature at that point in time to sort of tell us what this flavor of insomnia looked like, and in fact, what were the causes, and therefore what types of intervention should we do. So what I'm going to do now is just run you through this particular study and what we found, and then how it sort of got us thinking differently once we saw the data. And so this was published in Behavior Research and Therapy. So firstly, when it came to the sleep onset associations, What we did have a look at was the type of associations that they had, whether it was at the start of the night or during the night. So if you look over on the left on this pie chart, we've got basically that a quarter of the sample were needing these associations at the start of the night, but not necessarily during the night. And when we're talking about associations, we're really talking about having the parent nearby in order to fall asleep. Then you can see this little white sliver. And what that is that these kids were okay falling asleep by themselves, but then when they woke up during the night, they needed their parents' help in order to go back to sleep. But clearly the biggest group here is that they need intervention all the time. They basically can't fall asleep or return back to sleep unless they've got a parent nearby. So that can be incredibly disruptive for the parents. And so what I'm going to present now is some of the data that we found at the end. So we did a randomized control trial, having a look at this CBT intervention that we had to develop and comparing it to a waitlist control group. And so these are really the sleep diary results here. So in terms of sleep onset latency, you can see here with the waitlist group, pretty stable over time, but with the CBT group from pre to post treatment, we see a significant reduction in the time taken to fall asleep. And then that remains stable by the 1 month follow-up. When we look at wake after sleep onset, again, you can see here with the waitlist group that it's nice and stable. And with the intervention group, we're basically dropping down towards 0 and maintaining that reduced wake after sleep onset at the 1 month follow-up. So this was actually quite reassuring. Then what often happens is that when you're doing some sort of insomnia intervention, you want to have a look at maybe some sort of other daytime functioning or emotions. And I want to sort of focus here on what we noticed when it came to the children's anxiety, because as I've already hinted, these kids are basically needing their parents nearby. So it suggests that there's some sort of anxiety that's also occurring. And what we found is that there was a significant reduction, more so in the CBT group when it came to the total anxiety score. And clearly it does sound a little bit like separation anxiety. And I must say, for these particular kids, it wasn't necessarily separation anxiety that was occurring 24/7. So these kids could actually separate from their parents during the day. When it came to nighttime, they had a lot of difficulty doing that. But we also found significant reductions in interaction effect here for separation anxiety as well. Now, this may not seem quite unremarkable, but the thing to sort of put this into context was when we were trying to develop this particular CBT for school kid insomnia, there wasn't anything around at that point in time. All we knew basically was what was being done with behavioral sleep medicine with adults, as well as CBT for anxiety disorders in kids. So what we did was almost like pick the best parts from that and put it together. So in some ways it makes sense that you're going to see anxiety scores decrease because you're starting to take elements from CBT for anxiety disorders in kids. However, keep in mind, what we're seeing here are reductions that are occurring after having 6 treatment sessions. And these reductions are equivalent to what you see in CBT for anxiety disorders. However, they take 10 to 12 sessions. So we're getting the same sort of reductions in half the amount of time. So that really had us scratching our heads thinking, what's going on here? And it really sort of suggests that potentially there was something happening within the behavioral sleep medicine components that may be accelerating these reductions in anxiety. So to sort of tell you a bit more about the CBT for insomnia that we came up with, like, as I mentioned, is 6 sessions and it was for school-aged children. And so what we did is for the behavioral sleep medicine components, we took sleep education. So we had to basically educate the parents as well as the kids about how much sleep they need, inform them about things like sleep homeostatic pressure, for example, as well, talk about sleep hygiene, and also bedtime fading. If you haven't heard of bedtime fading, very similar to sleep restriction therapy that we perform in adult insomnia. However, it's done with infants and preschoolers, but we just applied it basically to school-aged kids. Then when it came to the CBT for anxiety disorders, we basically took cognitive restructuring from there, making it very specific to the sort of things that we were hearing from kids. A lot of these kids were basically hearing some sort of sound outside at night. And because they're awake, they were starting to fear the worst. And that's when they would go and seek reassurance from their parents. So we really had to get them thinking a bit more in depth and analytically about their thought patterns and what they were initially coming up with in terms of what made that sound, get them to sort of do a bit more reality testing and generate different sorts of thoughts. And because a lot of these kids really did need to have their parents nearby in order to fall asleep, we had to do some exposure therapy as well, and really exposure to separating from their parents. And to give you a bit of a flavor, we'd have different sort of situations when it came to the kids needing their parents nearby. Sometimes the kids would be in their own bed, but the parent would have to be with them in their bedroom until they fell asleep. Some kids were sleeping on a mattress on the floor of the parents' bed. Some of them were kicking dad out and he was in the kids' bed and they were sleeping in dad's place. So there were different ways of trying to sort of change them in some sort of ways, but it was essentially trying to separate them from their parents gradually over time. And we also performed relaxation training in the hope that that was going to help some sort of de-arousal. But in this particular paper, we started to postulate that, and I'll quote it here, what is yet to be determined though is whether the addition of bedtime fading and sleep hygiene education provide added benefits beyond anxiety-focused techniques like graded exposure. So we're really starting to postulate, is there something happening with basically behavioral sleep medicine that is helping to accelerate some of these anxiety decreases that we were seeing? And so we went back into the literature, and this was a great paper by Professor Rondal. I always have to think before saying your name. I'm sorry if you're in the audience. And Professor Alison Harvey. And they were really looking at sleep in different sorts of emotional disorders, one of them being anxiety disorders. And reading between the lines, you could see that there was some sort of mechanism at play, or mechanisms, when it came to that relationship between sleep and anxiety for school kids. And to sort of really provide some statements for it, here we go. There's a couple of dot points here. Children with less opportunity to be awake in bed worry less. So that example that I provided before, where kids are taking a long time to fall asleep, they hear a noise outside, then they start to worry, start to panic, and then they'll start to get up out of bed and go seek assurance from their parents. So basically lying in bed, especially for an extended period of time, as you know with adults, it gives them more opportunity to worry. So that's one potential mechanism linking sleep and anxiety. The other one was also quite interesting. Sleepiness dampens the arousing effects of anxiety. So often what we'll see is that we're increasing sleepiness when we're doing something like sleep restriction therapy with adults. And it's possible that that physiological increase in sleepiness is helping to dampen that physiological decrease in that hyperarousal that's associated with anxiety. So from here, what we managed to do is start to have a talk, particularly with Alison Harvey, as well as Jenny Hudson from Macquarie University, and start to sort of think about how can we actually look at this relationship between sleep and anxiety in kids, but also go a little bit further, a little bit deeper, and also test the mechanisms that might be involved. So from what we're doing here is we're shifting from treating insomnia in school kids. Hopefully I've shown that with CBT for insomnia, yes, we can actually do that. And we started to get interested in the mechanisms. So how does this actually work? And we wanted to look at these two particular possible mechanisms and see which one might be at play here. So I'll try to step you through this when we sort of think about what we do in therapy, especially like, say, for instance, when it's done with adults, doing something like sleep restriction therapy. But first, what I'm going to do is I'm going to talk about the control group, because what I'm presenting to you right now is really the framework for the remainder of the RCTs that we did. And we had to sort of think, we wanted to go beyond doing a sort of waitlist control group. We actually wanted to have an active control group that would help us test these mechanisms. So as an example here, this is a visual sleep diary where the downward arrows mean going to bed, upward arrows mean getting out of bed, the lines basically are sleep. And if we look at this as a pre-treatment sleep diary, and we look at the average over 7 nights, we come up with something like time in bed equals 11.2 hours, but the average total sleep time is 10 hours. This is obviously for a school kid, not necessarily for an adult with insomnia. So when thinking about a control group, what we wanted to do is that we wanted to look like that we're actually doing something. We wanted to have an active control. So these kids and these families would come in and see us, and we would be doing certain techniques. Now, sometimes the treatment as usual approach is really to regularize bedtimes. And if we do this, for example, and you see here at post-treatment, if we were to do this, the time in bed would actually remain the same, 11.2 hours. And what we would do is take these irregular bedtimes and just make sure, try to ensure as much as possible that they were regular as possible. The key thing here is that we're not manipulating sleepiness and we're not manipulating the time awake in bed. So what we still theoretically should see in this particular intervention with these kids is that there's still opportunity to worry. They're not necessarily increasing their sleepiness. So do we still see that they're basically having this worry, not feeling sleepy, still experiencing some sort of anxiety here? Then if we take the opposite approach and we look at something like the classic sleep restriction therapy. Now, classic sleep restriction therapy in adults would suggest that if you average their total sleep time and it's something like 10 hours, then you should give them 10 hours of time in bed. But we were thinking about this and thinking that's not necessarily true sleep restriction therapy. Technically, we're not restricting their sleep. And in doing so, if we manage to actually restrict their sleep, then we should be increasing sleepiness, and then we can test if that helps to dampen anxiety. So rather than saying that we're going to now say that your new time in bed is 10 hours because that's your average total sleep time, we're actually shaving off 30 minutes here to sort of really restrict their sleep. So this was the therapy that we wanted to actually provide another group of school-age kids. Now, whenever we're sort of doing work with human beings, I should say, and especially with the sleep restriction therapy, and to give you background as well, I've worked with adult insomnia for about 20 years. There's always a worry that they go and do this particular treatment with you, you give them the guidelines for sleep restriction therapy, and then they walk out the door and they get in their car to go home. And so we certainly wanted to make sure that we were doing something that was going to be safe. So while we were doing all these randomized controlled trials in school-age kids over the years, we also conducted a study looking at the driving performance of adults when you give them 2 weeks of sleep restriction therapy. Fortunately, we weren't seeing these overwhelming impairments, but I would love to just inform people this really does need to be replicated so we can feel much more confident that this is okay. At least fortunately, you don't have to worry about kids. And in our particular sample as well, the kids didn't report any sort of driving, which is a really reassuring sort of thing as well. So what we did is we tried to apply for funding. We didn't get it year after year. In fact, our reports were getting worse. But fortunately, we had a PhD student who could help to really sort of drive this next randomized control trial, which was narrowly Kane. So in this particular study, we had 61 children and they were allocated to different groups, and I'll show you those in a sec. The average age was 9.1, 2 years standard deviation, age range between 6 to 14 years. Now, before we go on any further, you're going to see that that's quite a wide range. And certainly there are differences in terms of development compared to a 6-year-old to a 14-year-old. One thing that might sort of be going through your mind at the moment is potential circadian rhythm issues. Hopefully, I can reassure you that we can spot these circadian issues very well, and these particular children did not meet the criteria for any sort of circadian rhythm influence. In fact, if you looked at the 14-year-old to the 6-year-old, you could clearly classify them as having very similar sleep issues as one another, rather than anything that would be circadian. And we had slightly more females in this particular study. So firstly, we gave one group sleep restriction therapy. Their new time in bed was going to be their average total sleep time before engaging in therapy minus 30 minutes. So in that previous example, if the child had 10 hours of average total sleep time, their new bedtimes would be 9.5 hours in bed. Then what we did is we wanted to have a look at what happens if you do that sort of classic sleep restriction therapy that's done with adults, where you have a look at their average total sleep time, which say, for instance, might be 10 hours, and then give them that time in bed opportunity. Now, technically, you're not restricting sleep, but you are restricting their bedtimes. So for this particular group, we called it bedtime restriction therapy. And then we had our bedtime regularization control, which was to say, okay, let's have a look at your time in bed just before you entered into this treatment program. We're going to give you the same time in bed. So really what we should see is that compared to the control group, both restriction therapies, we should limit the amount of time they are awake in bed. And that will tell us if there's something going on in terms of worry. And if we have a look to the sleep restriction group, not only should they have a reduction in the amount of time awake in bed that reduces their worry time, but they're also going to get this added mechanism so that they start to feel more sleepy. So do we see differences between the sleep restriction therapy group on top of the bedtime restriction therapy group? For this particular study, we were looking at sleep, so sleep diaries in this case. We were also looking at anxiety, just like the previous study with Sarah Payne. But we also wanted to look at these process variables, these mechanisms. So we also measured worry in the children, as well as sleepiness. And I should say that it was sleepiness that was really confined to the evening, not necessarily daytime sleepiness. We did measure daytime sleepiness, and I will sort of talk about that later on. So here are some of the results. So firstly, time in bed. So we wanted to look at time in bed as a manipulation check. Did they actually concur with the instructions that we were providing them? And so for reference, the light gray here, the top one, the top line, that is the control group. So you can see some reasonable stability over time. And these measures were taken at pre-treatment after 1 week of treatment. So after that first week of implementing the technique, where you can actually see most of the effects occurring, and then after 2 weeks. And then we did a 1 month follow-up. And you can see here that there's a significant interaction, and it actually turned out quite well. So reasonable stability with the control group, both the bedtime restriction therapy and the sleep restriction therapy groups really just did adhere to the instructions that we provided them. Then when it came to some of the insomnia that we see, when it firstly comes to sleep onset latency, we did find a significant interaction effect. And again, you're seeing some stability here with the control group. So they're still taking about the same amount of time to fall asleep. Interestingly, we're not seeing any differences between both restriction therapy groups. We're not seeing extra improvement in the sleep restriction therapy group. They're pretty much following the same sort of pattern there. And then for WASO, wake after sleep onset, we didn't find a significant interaction. Looks like we have a bit of a floor effect. They can't really go down much more. But what we're seeing here is not really much difference between the three groups whatsoever. So what happens in terms of the mechanisms? Well, firstly, having a look at evening sleepiness, and we did find a significant interaction effect. So what we're seeing here is, again, is reasonable stability in the control group. So we're not manipulating as much as possible their time in bed. But with both restriction therapy groups, we are seeing that they are having this increased sleepiness. Again, really interesting that there's not any differences between the two restriction therapy groups, even though one is intended to restrict their sleep. They're very much following the same sort of pattern here. When it came to worry, we didn't find any significant interactions here. So none between any of these different groups. So in terms of mechanisms at this point in time, it is suggesting that the improvements in sleep might be occurring because of this increased sleepiness. And maybe this increased sleepiness is the mechanism for explaining this link between sleep and anxiety. Well, that would be true if we found things happening for anxiety, but in this particular case, over a 2-week period, and then with a follow-up, we're not seeing significant interactions between the control group and the restriction therapy groups. And that's both for the total anxiety scores and also for the separation anxiety scores. Remember, the very first RCT that we did find significant interactions between a waitlist control group and the CBT. One thing I will mention at this point is that we did see main effects for time for both of these different variables here for all three groups. So all three groups were actually improving, or I should say reducing their anxiety scores over time. It's just that they were doing it at the same rate, but there was no differentiation between the three of them. So really, when it comes to this restriction therapy and how does it work, what has this study really told us? Well, we are seeing improvements in sleep latency. So I guess we've had that replication now across 2 randomized control trials. And in this particular case, it looks like that's happening because of the evening sleepiness and an increase in that. So it's hinting that there might be something to do with the sleep homeostat there. Now, there were no significant differences that we could really find between the sleep restriction therapy group and the bedtime restriction therapy group, which suggests that you don't necessarily need to go hardcore and do something like restricting kids' sleep. That being said, I will say from a clinical standpoint, there were certainly some kids where we could see that if you provided something like sleep restriction therapy, you did get great results really quickly, like sometimes meeting their clinical outcomes, their actual goal for treatment within 1 week. It's just that probably what's happening here is that across the whole group, we're not necessarily seeing that relative to bedtime restriction therapy group. So the results might not necessarily be reliable, but when you're applying this information, I guess, clinically, if you go and do, you might get better success with some kids for sleep restriction therapy. So we did find declines in worry and anxiety, but we're not seeing that differentiation between those three groups. So what is this really telling us? Well, it's not due to the restriction therapies per se. We can't really say that they're the explanation for why we're sort of seeing these changes in worry and anxiety. So when we're looking at the common denominators between the control group and the restriction therapy groups, we have to sort of think regularity was common across all of those three. When you're doing something like restriction therapy, whether it's sleep restriction therapy or bedtime restriction therapy, or just regularizing their bedtimes, you are setting set bedtimes across the week. So maybe there's something happening there when it comes to the regularity. But also we have to consider that there's plenty of studies across, say, for instance, clinical psychology, where you have that therapist attention and that therapeutic alliance. And is that having an effect there when it comes to reducing worry and anxiety across these three groups? That's another common denominator there. And so it's been interesting that while we've been doing this process and we've been looking also at what are the mechanisms involved in this particular case when it comes to sleep and anxiety, there's been some great work done from Leonie Mora, if I've pronounced your name right, and her group looking at what are the mechanisms really trying to explain sleep restriction therapy in adults and how it works. Now, clearly, you probably have had this thought come through your mind, what the F are you doing? Like restricting kids' sleep. I mean, are you mad? I'm telling how all of these families, all of these talks in schools and everyone I know how important sleep is. And here you go restricting it. Yes, we thought of it as well. So we thought before we really embark and start to do data collection, we should sort of think, what are the things that can go wrong? And so we systematically measured those as well. So one thing we did is that the kids did a computerized version of the NEPSI, and we took several particular subtests from the NEPSI. It's really looking at processing speed, sort of those sort of simple types of cognitive processes. And we were really matching that from that classic study by Avi Sadeh, What a Difference an Hour Makes, where he basically did a study doing sleep restriction as well as sleep extension and having a look at how that affected cognitive performance. We also got teacher ratings as well of the schools, the kids' attention in schools. And I mentioned before that we looked at evening sleepiness. We also measured daytime sleepiness because there's no point in increasing evening sleepiness to get those benefits with sleep onset latency if you're going to get some, harsh things happening with their daytime sleepiness. And one thing that can happen, especially in preschoolers, if you do any sort of sleep restriction, you can actually get parasomnias occurring as well. And this hasn't been well studied when it comes to school-aged kids. So we also wanted to look if there were any new occurrences of parasomnias. And that included kids that had a history of parasomnias or had current parasomnias. So in other words, does that get in the way of treatment? So I'm happy to report that between all three groups, keeping in mind that the regularization group, we didn't restrict their time in bed, at least not on purpose. And we're seeing that there was no significant interactions in all of these different outcomes here. However, we found some interesting things happening in the NEPSI, where we did see some changes occurring over time for all three groups. And so where we saw improvements over time was in the serial digit learning task and the symbol digit substitution task. If you're not familiar with these tasks, the basic thing I can say is when kids are doing them in a repeated fashion, they could possibly learn certain tactics or strategies in order to improve upon them. And that's potentially what was happening here across time. But we did see reductions in simple reaction time. In other words, decrements in that over the 2-week period that they were doing this. And that's regardless if they were doing sleep restriction therapy or regularizing their bedtimes. We just saw this degradation occurring. Now, it's hard to know exactly why that's happening, especially if we're not reducing sleep or even sort of time in bed for all three groups. I don't know if the kids got bored, so it's a question of whether that can be replicated, and we can see that happening again. But I guess the good news here is that we have found some sort of effective treatment for school kid insomnia that can be done fairly briefly, and we're not necessarily getting these poor outcomes. So we started to then think about, okay, we're getting a lot of self-reports, and there was this great work that was being done looking at adult insomnia and why it works. And so we had the opportunity to also objectively measure sleep and have a little bit more of a closer look at these kids' sleep architecture when we were doing these therapies. And this work was led by Emma Hunt, Hannah Wetham, and Meeks, aka Mikhail Khan. I still can't say her name, Mikhail, it just hurts. And so in this particular trial, we had 26 children, again, aged fairly similar sort of age range as well. And this time we just wanted to sort of take the two extremes. We wanted to continue using our bedtime regularization control group and have a look at the sleep restriction therapy group. Because we're doing polysomnography and we're doing this pre-post after a 2-week period, before treatment and after treatment, we didn't necessarily have the logistics to sort of be able to do it at 3 time points and to do it across 3 different types of therapies here. So we just wanted to take the extremes. And so we had a look at their sleep, obviously, because that's what we're measuring. And in this particular moment, I want to really focus on the polysomnography data because that's the new fresh data. We're starting to see replications occurring anyway when it comes to sleep diary data. And clearly we want to have a look at the slow wave sleep and what is happening here when we're doing something like sleep restriction therapy in comparison to bedtime regularization. And so here's the results in terms of the polysomnography total sleep time. And you can see here on the left-hand side with sleep restriction therapy that we've got a reduction, even though we're saying to them, reduce your time in bed so that we're shaving off 30 minutes. We actually find on these particular nights when we're doing polysomnography that we're getting a reduction in 52 minutes for the sleep restriction therapy group. Even for the bedtime regularization group, we get this reduction of nearly 30 minutes there. So you can see, though, we're just certainly getting a greater decline in total sleep time when it comes to sleep restriction therapy group. So in terms of the insomnia symptoms, we're getting replication occurring this time with polysomnography for sleep onset latency and getting a reduction of over 30 minutes. Many clinical significant improvement indicators happening for that group over there. And a slight improvement, if you can say that, 6 minutes for the control group. You probably might sort of say it's more stable, if anything, there. In terms of wake after sleep onset, now, unlike what we were seeing when it came to the sleep-wake diary data for the 2 different trials, we're actually seeing something like 16 minutes shaved off for wake after sleep onset, although we are starting from a higher sort of baseline here of nearly 40 minutes, but almost a 50% reduction when it comes to sleep restriction therapy and wake after sleep onset, and reasonable stability there for the control group. But what we're here for is really looking at the sleep architecture. So looking at the combined stage 3, stage 4 minutes is the unit of measurement here. We're seeing that despite a reduction of total sleep time of 52 minutes, that the combined stage 3 and stage 4 for the sleep restriction therapy group is an increase of 13 minutes. And despite the fact of a near 30-minute decrement in total sleep time for polysomnography, we're seeing reasonably stable 2.4-minute reduction in the control group there. And so when it's displayed as a percentage, we're seeing here that despite the fact that we're reducing the amount of time of sleep for the restriction therapy group, we're seeing just a slight 6% increase percentage-wise of stage 3 and stage 4, and reasonable stability as well for the control group, even though they had a 20-minute decrease in total sleep time. So really sort of nice to sort of see that despite the fact that we are restricting sleep here, we are seeing not necessarily a restriction of stage 3 and stage 4, we're seeing that nice homeostasis at play. And clearly it's almost suggesting again that it's really sleep homeostasis that's certainly driving those improvements in sleep onset latency for these school-age kids. So when it comes to this topic of this keynote, treating insomnia in school kids. How does it work? Summary conclusions can be insomnia occurs in school kids. Please remember that it does not just happen when you turn 18. CBT for insomnia in kids is effective. If you combine those cognitive and behavioral techniques, we're seeing improvements in many different facets of their sleep. I should also mention, although it wasn't necessarily part of this talk, that parents were very happy because they got their kids out of the bedroom, although some weren't so happy because then their husband came back and, snoring and all that sort of stuff. Restriction therapies in kids are effective, and they also appear to be safe. I would love to see some replication, not only for school kids and seeing the safety of being able to do restriction therapies, but also for adults as well. In terms of the mechanisms, and I think this is the research that I really love to look at, like how are these things working, how are they connected? At this point, it looks like the thing that is driving those insomnia improvements is sleep homeostasis, as would be expected. But when it comes to the improvements in anxiety, I think what we still need to be able to do is really have a look. Is this about therapist attention? Is this about regularity? And coming up with some sort of design or designs that are able to really tease that out and try to understand how much that's really the sort of mechanism at play when it comes to these improvements in insomnia and these decreases in anxiety. So we certainly need much, much, much more research to be done in this particular area. And to that point, here's this mock-up sort of graph that I've just developed for this conference. So on the y-axis here, we have the number of published studies, and along the x-axis, we have the different age groups across the human lifespan. And I would predict that if you're looking at sleep problems in these particular groups, you'd have something like this U-shaped sort of curve, where there's certainly a decent amount that happens with infant sleep, certainly with adult insomnia, and there's been a lot more teamwork that's been happening as well. But really, there's only a few of us in this sort of area that are having a look at this particular age group. It's really vacant. We talk about how important sleep is, and we have to do all this research. This is probably the group that's missed the most. So, whether it's Lisa Meltzer, John Kwok, Angelica Schlab, I hope I got the pronunciation right, Candice Alfano, there's only a few of us doing this. So I really hope that maybe this talk has inspired some of you in the audience to sort of think, yeah, we got the opportunity to do this, or I'd love to have a look at this sort of work. Because quite frankly, school-age kids, they project less body fluids in clinic than babies, and they laugh at your jokes more so than teenagers. So they can actually be a great group to work with. And of course, in terms of talking about a great group to work with, it's just amazing to be able to present these results to you over this sort of 15-year span. And clearly there's been thousands and thousands of hours that's been dedicated to doing this, a huge array of teams upon teams. I thank every single one of these people as being sounding boards for driving this research and having a lot of fun along the way. Thank you.